Okay, so if you want to advance to next slide, we're going to start talking about genetics. Some of the topics that we're going to address today is the difference between hereditary cancer and sporadic cancer, who may benefit from a referral to genetics, what's the difference between genetic testing of tumor and blood, why consider having a genetics evaluation, what's involved, and then how does the diagnosis of a hereditary cancer syndrome help with medical management for a cancer diagnosis, and then also very importantly for cancer survivors, how to prevent future cancers and how to help your family with potential cancer risk. So, it turns out that most cancer is actually not hereditary. So this pie chart kind of represents the pattern for most solid tumors, like breast cancer, colon cancer. It's kind of surprising sometimes when people get these types of cancers and they think, well, gosh, I have no family history. I don't know why I got cancer, especially a young person can be pretty shocked when that happens. But when we do genetic testing, we find that only a small slice of the pie has, just that 10%, has a hereditary explanation. There's an additional 20% where we still observe a pattern of cancer in the family, but even if we test the person that has cancer, we don't find anything. So we think there are potentially factors we don't understand yet, maybe combination of genetics and environmental factors, lifestyle factors that a family can share, but we don't have a gene mutation we can put our finger on. And then the rest of cases, the majority, about 70% of cases, are sporadic, meaning just one person in the family has cancer or has that type of cancer. So just by sporadic, what we mean is that it's caused by chance, environmental factors, unknown factors, or potentially even very weak genetic factors, maybe lots of factors that we can't put all together. But it's just an observation, only one person had the cancer. But typically, we see that happens with later age of onset, like cancer over age 50. And also with sporadic cancer, we see fewer cancer occurrences in a family. So we don't see a really striking family history. Okay, next slide. So this looks like a sporadic cancer to me. This is a family tree where males are squares and females are circles. So the arrow is pointing to the lower left circle. So that's the person that is coming in, who's the patient, and her mom didn't have cancer, and her mom's two brothers didn't have cancer, but her maternal grandma had breast cancer at 88. And this is not a family that we would be really concerned about as having a gene mutation causing the cancer. Now, hereditary cancer, on the other hand, is caused by a mutated gene that's been passed down from the parents. Usually the inheritance is what's called autosomal dominant, which means if someone has a mutation, there's a 50% chance of passing it on to their child. And the individual who carries a genetic mutation has an increased risk of cancer. And hereditary cancer tends to be associated with a young age of onset, like under age 50. Now, this is like a textbook hereditary pattern of cancer. And believe me, they don't all look like this, even when it's hereditary. But in this situation, let's say you're starting with the bottom row. And Jacob, if you just want to highlight the breast cancer 30. So let's say this was my patient, had breast cancer at 30, mom had breast cancer at 50, maternal aunt had ovarian cancer, the slash means they're deceased. Grandma had breast cancer at 47, deceased, and so on. There's prostate cancer in the family. This family, to me, has a very high probability that we would detect a mutation if we were to test somebody in the family who had cancer. And so this looks hereditary to me, so very different from the other family tree. So what are the key features? And like what types of cancer do we think could be hereditary? Well, this whole list in the first bullet: breast cancer, uterine, colon, stomach, brain, any other gastrointestinal cancer diagnosed under age 50. These are all people who deserve a genetics evaluation, and we would want to see in our clinic. So anybody with ovarian, pancreatic, male breast cancer, it doesn't even matter what age they have it. Even if they were diagnosed at late ages, we still feel they should be evaluated for hereditary cancer, because these types of cancer are more likely to be hereditary. Prostate cancer, if it's an aggressive type, like Gleason 7 or higher, and or under age 50. I should have added under age 50 there too. Sarcoma under age 50, rare tumors like an ocular melanoma, adrenocortical carcinoma, and then also I added here melanoma, if there's a family history of melanoma or any of the other cancers listed above. So these are all the types of cancers that we typically see in our clinic that we feel feel like it's worthwhile to check to see if there's any kind of underlying hereditary reason for cancer. Okay, so then here are some cancers that are not typically associated with a hereditary cause. And some of these are quite common, but usually these are not ones that we would see just as a standalone diagnosis. So cervical cancer tends to be caused by the HPV virus. So it's more of a viral cancer. It's not usually hereditary. Lung cancer, usually related to smoking, and also not usually associated with a hereditary cause. Testicular cancer is a little bit puzzling because there are certainly genetic factors that relate to testicular cancer, but it's been much more difficult to identify those factors, to test for the right genes and to interpret the results. And unless there's a family history, we typically do not see testicular cancer as genetic. Then there's leukemia, lymphoma, typically not genetic, and thyroid cancer as a standalone. But now pretty much all of these, if there's a family history that could be potentially concerning for genetics, that, like, for example, with the cancer types that were on the last screen, if they're in combination with some of these cancers, there could still be a hereditary component. And there are some just very rare syndromes as well, like, for example, families that have leukemia generation after generation, and then there is a genetic explanation, but that is very much the exception. So we're going to talk about a couple different syndromes. I'm going to talk about hereditary breast and ovarian cancer syndrome and show you a case example of how we found that. And then Jacob's going to talk about hereditary colon cancer syndrome and how that was found. And so for the hereditary breast and ovarian cancer syndrome, this is a syndrome that's caused by a mutation, an inherited mutation in BRCA1 or BRCA2. And it's associated with an increased risk for breast and ovarian cancer. And then in men, also increases the risk of pancreatic, prostate, and male breast cancer. And you can see here that the lifetime risk of cancer is quite high. On the left shows the female cancer risk. So risk for breast cancer is very high. It's not 100%, so someone could still live their whole life and not get cancer, but you can see that breast cancer risk is high. And if they get breast cancer, then the chance of getting another breast cancer, another breast is high. Ovarian cancer risk ranges depending on which gene. It's higher with BRCA1 than BRCA2. And then men have increased risk as well, most notably prostate cancer, and it can be the aggressive type of prostate cancer, and it can occur at a younger age. And then to a lesser extent, there's other risks as well, such as male breast cancer. And then in both men and women, there's increased risk of pancreatic cancer and melanoma, most notably in BRCA2. So there's a whole bunch of things to talk about if we find a mutation carrier. And so I wanted to show how finding out this information really influences breast screening, because sometimes people say, well, gosh, I'm getting a mammogram anyway. Why do I need to even do genetic testing? Well, here's why. Because the screening really differs. So along the horizontal line in the middle there, it shows patient age. So let's say you're talking about the general population. General population is recommended to get mammograms between age 45 and 75. Sorry, it's not lining up there for some reason, but it's supposed to be lined up between 45 and 75, the blue arrow. But BRCA1 and 2 carriers, they start their screening much younger. They start at age 25 and go up to 75. And it can go even beyond 75 in both situations, depending on the health of the individual. But the screening starts at a much younger age. And BRCA carriers also have annual, in addition to having annual mammograms, they also have annual breast MRI. And MRI can be a more sensitive test and can catch breast cancer at an earlier stage, especially some of the BRCA1 related cancers that can be very aggressive. So the screening is much more intensive. They're getting screened with both every year and starting at a younger age. So sometimes I hear people saying, well, you know, this relative's already getting a mammogram, they don't need testing, but it actually does make a big difference. And ovarian cancer risk is also a very important part of this syndrome, because unfortunately screening for ovarian cancer with ultrasounds and blood tests is unreliable, can't pick it up early. So unfortunately the recommendation is to surgically remove ovaries and fallopian tubes after childbearing is complete. So this can be a very challenging part of having a mutation for women who don't necessarily want to part with their ovaries when they're only 40 years old, for example. One of the other things that could be done, oral contraceptives actually reduce the risk of ovarian cancer. So for young women, we recommend taking oral contraceptives because it can reduce the risk of developing ovarian cancer. When taken for, say, 5 years, it reduces the lifetime risk by half. So that's pretty significant. And I should say that's not just with BRCA carriers, that's in the general population as well. And then men, we recommend prostate screening starting at 40, and then also breast screening and awareness of potential risk of male breast cancer. And then one of the other things I wanted to say and how this can affect cancer treatment, and this could be for people who have not necessarily just breast cancer or ovarian, but even pancreatic and prostate cancer, is there are now, there's FDA approval of PARP inhibitors. And this is a special type of chemo that blocks an enzyme called PARP. And for you science folks out there, PARP is an enzyme, and it stands for poly-ADP ribose polymerase. And PARP normally repairs damaged DNA. And if PARP is blocked, it's actually toxic to cancer cells that are defective in BRCA1 or 2. So that results in the death of those cancer cells. So that can be a very important targeted treatment it would be given by an oncologist, usually in an aggressive cancer or advanced or metastatic cancer. But recently for breast cancer, there has been some very exciting data showing that it can be helpful even in early stage breast cancer. So we're really excited about targeted treatment to the genetic mutation which caused the cancer. And then I wanted to present a case of kind of an incidental finding of a BRCA mutation. This was a 33-year-old woman who was referred. She was a USC patient. She had, unfortunately, metastatic cervical cancer, which had spread to her liver. And her family history, as you can see, is significant for some cancer, but not a ton of cancer. So she has maternal aunt who had breast cancer at age 48. And then her maternal grandfather who had died of cancer, died of causes unrelated to cancer, but had cancer at age 91. But she didn't know what type of cancer it was. There were definitely some important psychosocial issues going on with this patient because she was diagnosed with advanced cancer and she had a 1-year-old. So this was a really difficult situation. And she also lived at a distance from USC. So even traveling to make these appointments could be very challenging for her given her baby. So next slide. So there was a genetic test of her tumor material that was done from a liver biopsy. And you can see, and maybe Jacob, you can circle that BRCA2, that one. That was something that her oncologist thought, oh, well, that's unusual, there's a BRCA2, because BRCA2 is not usually related. And it lists some other mutations there, which are not really relevant for heredity and don't really provide an explanation for her cancer. So the oncologist identified this mutation and referred her to genetic counseling for further evaluation. And this was actually a pretty intense situation, because this young woman was, she had finished her chemo, she was going to have radiation, and then she was going to be having surgery. And then the question was, should she have her ovaries removed when they take her cervix and uterus, or should they keep her ovaries? And she was very young, she's only 33, and so normally we wouldn't remove ovaries so young, but her doctor had determined that based on the radiation and the chemo, I think just the radiation, that her ovaries would not be functional. So she was not going to be fertile in any case. So it wasn't it wasn't going to really interfere with her quality of life if her ovaries were removed, but it would be really important for cancer risk reduction, so she wouldn't get ovarian cancer. So I saw her for pre-test counseling and told her about BRCA2, about the risk of both breast and ovarian cancer, and the potential to impact her surgical decision-making. And she underwent a blood test, and the blood test confirms the BRCA2 mutation actually was an inherited mutation. So this shows the BRCA2, it says pathogenic mutation. It lists off some letters and numbers, which it turns out is the same mutation as was on her other report, just described in a different way. So while BRCA2 is actually not the explanation for her cervical cancer, this was an incidental finding, but it did impact her immediate surgical decision-making, and she ended up having her ovaries removed. So she would not eventually get ovarian cancer. And then counseling was provided about future breast cancer risk and about her family members, such as, for example, her mother or other relatives in the family, even that aunt who had breast cancer, could potentially have this test and find out if she had a risk of ovarian cancer. So there's a lot that can be done for prevention for her relatives as well.
Thanks, Julie. So great explanation of hereditary breast and ovarian cancer syndrome. Another common cancer syndrome that we often see as genetic counselors is a condition called Lynch syndrome, which, as Julie alluded to, is primarily conferring risks for colon cancer, endometrial cancer, and ovarian cancer. This particular syndrome is caused by a mutation in one of 5 different genes. And just to, I guess, give a little bit backstory about genes, I'm sure everyone's heard of them, but basically genes are important for the functioning of all the cells in our body. So we have a copy of every gene from mom and a copy of every gene from dad. And so the genes that we're really concerned about, primarily as cancer genetic counselors, are the ones that are important for defending us from cancer. These particular genes associated with Lynch syndrome are important for fixing certain errors in the DNA. And when they're not functioning properly, someone can be at an increased risk for cancer. And I just wanted to lay that foundation because that's sort of going to be important for some of the case examples that I discuss here. So in addition to protecting organs, this is uterine cancer and the ovaries, these genes also can help protect the stomach from developing cancer, the pancreas, urinary tract, and other cancers as well. So, but I think most people think about Lynch as a colon cancer syndrome, and then the uterus and ovaries that are the next most common types of cancers involved. And we'll talk more about it. So this is what you might typically see in a Lynch syndrome family. And again, circles are squares, as I'm sure you figured out, and squares are males. So someone might be diagnosed with a colon cancer, and this one is past 50 years old, but sometimes we can see that these colon cancers are happening younger on in someone's lifetime, unfortunately. But we can oftentimes see a family history of related cancers such as colon cancer and even uterine cancer at younger ages as well. So these sorts of personal histories and family histories raise suspicion that there could be Lynch syndrome that warrants or merits assessment from a genetic counselor. Now, should we find that someone harbors a mutation in one of those 5 genes that basically gives them the diagnosis of Lynch syndrome, there's things that we can do as far as screening and prevention, similar to how we can offer screening and prevention for hereditary breast and ovarian cancer syndrome, except these are, the management recommendations are tailored to the risks of the syndrome itself, obviously. So we might recommend earlier and more frequent colonoscopies and getting upper endoscopies to screen for the stomach cancer and small bowel cancers that can be slightly increased in this population as well. When it comes to the uterine cancer and ovarian cancer risks, it's a little bit nuanced and tailored because some of the risks, I would say Lynch syndrome is sort of a spectrum of risk. So some of the genes might have higher levels of risk for ovarian cancer and uterine cancer, and others might have much lower risks for those types of cancers. And so oftentimes it's really just a consideration, not a recommendation as it is for BRCA1 and BRCA2 to have the ovaries removed, but something that someone can consider once they're done having children. With uterine cancer, we are normally able to see signs and symptoms of that cancer, and so it can be treated at an early stage. But as Julie mentioned, unfortunately, ovarian cancer can be diagnosed later on, and our screening is not as good for ovarian cancer. And so I think that goes into making the decision about whether to remove the ovaries for someone who has a Lynch syndrome diagnosis. Now, people who have Lynch syndrome get colonoscopies earlier, as I mentioned, usually in their 20s, but they also get them more frequently. And I'll explain a bit why that is. So right now, the general population screening for colonoscopy begins around 45. It used to be 50, but it's sort of moving towards 45 as the incidence of colorectal cancer is increasing. And someone would typically get a colonoscopy every 5 to 10 years, depending on the findings of their colonoscopy. If they're negative, then they might elect to have them every 10 years, meaning that no polyps are found. Polyps are basically just precancerous formations of cells. With Lynch syndrome, we can actually see that the acceleration of an adenoma, which is what I'm calling a polyp here, can be quicker from once an adenoma starts to develop, it can turn into a cancer much quicker than a polyp or adenoma in the general population can transform into a colon cancer. So the rationale is that with more frequent screenings with colonoscopies, these polyps and adenomas can be removed before they become cancerous, just because they can become cancerous so much quicker. And so the screening certainly saves lives and reduces the incidence of colorectal cancer in this population. There's also been some more recent advancements beyond just screening and prevention for individuals with Lynch syndrome. We know that people who have unfortunately been diagnosed with colorectal cancer who have Lynch syndrome might benefit from a class of drugs called immunotherapy, which harnesses one's own immune system to help fight the cancer and treat the cancer. And I'll explain a little bit about how this works. So the Lynch syndrome genes, as I had mentioned earlier, are really responsible for helping to repair little mismatches in the DNA. So they're very important DNA repair genes. I'll just make this person. So now, if someone's mismatched repair genes, their Lynch syndrome genes are not working, if there's a mutation in one of their copies, then they have Lynch syndrome. And that can be a problem, as we discussed, for increasing the risks. Now, someone who has Lynch syndrome, because they don't have these DNA repair proteins working to defend them from cancer, can develop colon cancers younger and at a higher rate, as we said. There's also distinctive features of these cancers that scientists have learned to basically harness from a therapeutic perspective. And there is a signature to these cancers that is called microsatellite high, or MSI high, that we oftentimes see. And of course, I wouldn't expect that anyone at maybe heard of these, but basically what this means is there's little telltale signs of these cancers that these particular genes are not working to repair those mismatches in the DNA. And so the cancer might express those certain signatures. Now, when that happens, we know we've recently discovered that immunotherapy can be used to target these specific signatures or the cancers caused by Lynch syndrome pathway. And that's because people with Lynch syndrome, their immune systems are actually primed to recognize these mismatches in the DNA with their immune system. So if we can just get the immune system to recognize that, then it can be more effective in combating the cancer. And so this is something that's been getting a lot of recent attention. So if we were to identify someone who has this signature, MSI high, then we know that they might respond better to therapy with immunotherapy in some cases. So it says my internet connection's unstable. Julie, am I frozen?
It froze for like 2 seconds, and now it's fine.
Okay, I'll just keep moving forward then. So I wanted to give an example of a Lynch syndrome case and what we might see as genetic counselors. And so there was unfortunately a 30-year-old male who presented with diarrhea, fatigue, anemia, and he had like 50 pounds of unintentional weight loss. He got a CT scan, which showed a colon mass, which was biopsied and unfortunately revealed colon cancer. So with anyone, and I'll explain about a little bit more about family history later, but with anyone, of course, we take a family history and we look for telltale signs, especially when someone's so young, that there could be other cancers that might raise suspicion for something like Lynch syndrome. So his paternal family history was really non-contributory, but his maternal family history had a few cancers that, or I should say a couple that we might start to suspect are related to his own diagnosis so young, including a uterine cancer at 64, and then in a more distant relative, a great aunt, an ovarian cancer, which was fortunately cured. As a sort of aside, there was, I guess, a little bit of question about whether prostate cancer might be related to Lynch syndrome, but it's not as established as the other cancers that we've talked about. And hopefully we'll learn more about that association in the future, if there is one. So as Julie also mentioned, it's commonplace at a center like USC to do tumor testing to see if there might be things that help drive treatment. So it's important to remember that the genes that we're born with are different than the genes that the tumor has. And there are certain signatures, I suppose, that we look for in the tumor that can help to drive treatment. And some of these genes might look familiar just because they're the ones that are associated with Lynch syndrome. And what this staining shows, this immunohistochemistry staining, is looking to see if the proteins are there in the tumor, basically, because if they're not, then that raises suspicion that the tumor could be driven by these genes being absent or not working to defend from cancer, like they're supposed to be repairing the DNA. So if these are, a couple of these were shown to be absent, suggesting that maybe they weren't working, and that's causing this other signature I told you guys about called MSI high or microsatellite instability. And we know that when something fits this profile, it can respond better to immunotherapy. They also look at a number of different genes in the tumor to see if there might be mutations that can be targetable with therapy. And a lot of these, as genetic counselors, we're really having to go through a table of genes like this and determine, well, are we more concerned that the cancer could be hereditary based on the genes that we see in the tumor itself, which we know are different than the genes that someone's born with. However, as you might reason, sometimes a tumor will still contain some proportion of the genetics that someone is born with because it arose from their cells. So one thing that we looked particularly close at is this MSH2 mutation, which is one of the Lynch syndrome genes. And given its frequency, which I won't go into, but basically it made us suspect that, okay, this is something that could be driving a mutation that's this person was born with that predisposed him to this cancer that he developed. But we don't know until we do testing on someone's germline, or which is just a fancy way for saying the genes that they're born with. So we did that. And what's nice about having tumor testing ahead of time before we test the genes that someone's born with is that we can clue the lab into looking for that particular change and let us know if it's detected or not. So indeed, this mutation was detected in this individual, confirming his diagnosis of Lynch syndrome. And there was some other uncertain findings, which are usually benign. Usually they don't change medical management. But what we were really concerned about was this, this mutation. And as you can see here in the report, it says that it's associated with autosomal dominant Lynch syndrome. And there's another condition I won't get into when someone inherits 2 copies of this mutation. Now, this really had implications for his treatment course, his future prevention for cancers, as we mentioned, but also for family members. And I'll explain a little bit more about the family history in a moment. Now, I'll sort of shift gears now, because what we're going to talk about is what we actually do during genetic counseling visits. And basically, before any testing happens, we're making sure that we get a comprehensive personal and family medical history. And a lot of times we're spending time looking through the medical records or looking at tumors, genetic reports, such as the one I showed you. But when we're actually meeting with the person, we go over some of this information with them, their personal family history, and make sure it's accurate. We get some ideas about what their concerns might be regarding their risk perception or motivation for testing, and address any psychosocial concerns that they might have. We also explain to them some of the concepts that we've explained to you guys today, which is cancer genetics and risks, and what the benefits of testing are, limitations, and how their management recommendations might change with their genetic testing status. In some cases, if there's a physician or a certain cancer syndrome, there might be a genetic focused physical exam. Typically, Julie and I are not the people who are doing that as genetic counselors, but it can be very important in some cases. And then we obtain informed consent, and genetic testing is really something that is anyone's decision to do. So we take a non-directive approach, but we, of course, see the value in it. So after we get the results, we will take time to interpret those results. So we'll do some variant searches sometimes, or search the literature and look up recommendations for management. We also want to, I think, first see how someone's doing with receiving that news and helping them understand it. And then we can talk about what it means to test family members and how that might be helpful as well. In some cases, we're able to do risk assessments even if someone doesn't have a mutation, but certainly with people who test positive for having a mutation, there are associated risks, and we try to do our best to make a calculation for what those risks are and make screening recommendations based off those. So as I mentioned, as promised, we'll talk about how genetic testing has implications for family members. So most of these mutations that confer cancer risks are inherited in a dominant inheritance pattern, which means that if a parent has a mutation, their child has a 50% chance of also inheriting that mutation. So we want to make sure that we're offering testing to people in the family if they're interested in doing that, so that they can understand their risks. And in some ways, those who are at risk who test positive are equipped with the information on how to manage those risks. But it can also be very reassuring for individuals who test negative to know that they're not at an increased risk for the cancers that were caused by this mutation in their family. So I think that's another benefit of it, but it's people's choice in the end. Now, it's very important, and one of the things that we spend some of the most time doing during the sessions is trying to get in an accurate family history. And that helps us identify whether someone might be at risk for hereditary cancer syndromes. It also can basically go into whether or not someone meets certain criteria for testing that we and the insurance companies go by. And it's important to make the distinction between certain types of information. So for instance, as Julie was mentioning, cervical cancer usually is not hereditary, but if someone's female cancer was not cervical and it actually was ovarian, then that might be something more concerning that we'd want to make sure that we know going into testing. Now, another one is abdominal cancers. I know anatomy is not my strongest suit, but if it's possible to ascertain whether or not an abdominal cancer in a person in your family with stomach, colon, or pancreatic, that can be extremely helpful for risk assessment as well. Now, this is just an example of the importance of getting a family history and I guess giving us as genetic counselors and you more information. This is what someone's reported family history that they knew about was, but oftentimes, and it sometimes might not be the most comfortable conversation, but it's sometimes important to ask relatives if they know about other cancer diagnoses in the family, or to take time to reach out to people and learn what they can. And if people are willing to offer that information, you might go from a family history that looks something like this to getting a family history that's expanded from that, where if you talk to your mom about, oh, did you have any cancers in the family? And she says, oh yes, my mother and my uncles and my cousin, and she was able to sort of give that information. That can be extremely helpful for understanding someone's risk for having a hereditary cancer syndrome, and also offering screening. So I think that's all I wanted to say, and I'll turn it to Julie, who can discuss genetic panel testing.
Thanks, Jacob. So in terms of what type of testing we do, most of the time when we see patients, instead of just testing for what we think they might have or what syndromes we think they're most relevant, we are actually doing panel testing. So we've been doing this since about 2013. So if somebody comes in, say they come in for breast cancer, before that, we would just order BRCA1 and 2. Now, since that time, since 2013, we've been basically ordering a full panel of genes. So there are a number of other genes that relate to breast cancer. Sadly, at other institutions or perhaps community practitioners, they might still just be ordering BRCA1 and 2. And sometimes we end up seeing those patients at USC and the doctors say, no, this isn't adequate just to do 2 genes. We want to have all of the genes related to, say, breast cancer. And it's also an opportunity for people to find out something that they wouldn't necessarily have known based on their family history, or to find out they have Lynch syndrome, for example, before they got cancer, so that they could be screened. So the panels that we do cover a lot of different types of cancer, as you can see from this list, and typically include something like 90 different genes, and even include rare syndromes. And just to give you an idea, this just shows one panel, an example, and this is just a subset of the panel, but you could see that, like, for example, BRCA1 and 2 can relate to, and it shows like the along the columns are breast cancer, ovarian cancer, BRCA2 relates to melanoma, both relate to pancreas, and then prostate cancer. So the red is like a very high risk, and the yellow is like moderately increased risk. So and you can see that various genes have associations with lots of different types of cancer. So this helps us in terms of screening families to make sure we're not missing anything. And if I see a patient and there's a new cancer diagnosis in the family, I feel more confident if they were tested for genes associated with some type of that type of cancer that may have not been present in the family history when I first saw them. Usually insurance coverage is really good for genetic testing. Sometimes people express concerns, but we don't have any issues with our visits being covered. All major payers cover genetic testing based on specific criteria. We also have some resources through a foundation that we can help to get testing covered for people who meet certain criteria. So the labs are always going to check your copay, and you can still decide if it's the out-of-pocket is too high, but usually we don't get too many complaints and the coverage is pretty good. Sometimes people ask about genetic discrimination. Could I lose my health insurance if I have genetic testing? And there's actually really good law to protect us against any kind of health insurance discrimination called GINA, which was passed in 2008. And it prohibits discrimination in health coverage and employment based on genetic information. So it can't consider like a gene mutation as a pre-existing condition. And then there's, but I will say that there's also kind of varying levels of coverage for life, disability, and long-term care, state by state. So that one should be somewhat more cautious if they were considering various other types of insurance, and maybe being careful and having discussion about whether genetic testing could impact other types. And so in conclusion, about 5 to 10% of cancer is hereditary, so it's more the exception than the rule. We discussed various types of cancer that could lead us to explore hereditary syndromes and have a genetics evaluation. We talked about some genetic test results that can influence cancer treatment. Sometimes it's surgery, sometimes it's chemo. And a genetic evaluation can also be an important tool in cancer prevention for cancer survivors. And that's why we thought this would be so important to share with this community of AYA patients, because you have a long life to live ahead of you and we want to keep you healthy. And it can also be important for your family members. So yeah, so that's essentially what we want to say. And we wanted to share with you our phone number in case you wanted to reach us. If you wanted to be seen, you can always send us an email that dl.usc-genetic or dl-usc-genetics@med.usc.edu. That's our best way of either self-referring or having your doctor refer, because then that message gets to Jacob and I, and also to our scheduler. So yeah, so at this point, I think we could just open up to questions. If anyone has any questions or comments or anything they'd like us to address, we're happy to do that.